Yeah. Good evening, friends. On behalf of Colitis Crohn's Foundation India, it's my pleasure to extend a very warm welcome to each one of you. This is the first in its series of IBD Masterclass, and we plan to continue this feature in the long run. First of all, I would like to welcome my co-chair and a dear friend, Dr. Saurabh Kedia. He's Associate Professor in the Department of Gastroenterology and Human Nutrition at All India Institute of Medical Sciences in New Delhi. He's a promising, competent, and committed young ibidologist of our country. And I have never said this, but I would like to mention that his humility makes him a great human being and a great colleague to team up with. I hand over to Dr. Saurabh Kedia to introduce the speaker as well as the topic. Dr. Saurabh, please.
Thank you, ma'am. Thank you for this kind introduction, and good evening, everyone. And first of all, my thanks to CCFI for giving me this opportunity. And it is my honor indeed to start the first session of the IBD Masterclass organized by the CCFI. And we all know that the alteration in the microbiome or gut dysbiosis has been implicated in various GI as well as non-GI disorders. And manipulating the microbiome is coming up as an effective and a promising treatment option for these disorders. Fecal microbiota transplantation is probably the most effective way to manipulate or to alter this dysbiotic gut microbiota. And to discuss upon the current status on this, we have a master for this masterclass, Professor Ajit Sood, who does not require any introduction, and he may be called as the doyen of FMT in India at present, and he has the maximum experience and maximum work on fecal microbiota transplantation. It is my honor and privilege to introduce sir to begin this session. Sir, please.
Thanks, Dr. Vandana, and thanks, Dr. Saurabh. So, fecal microbiota transplant, the current status. A human being is never alone. There are trillions of organisms residing in our body. The composition of slide. Right, thanks. FMT, the current status. Human being is never alone. There are trillions of organisms residing in our body. The composition of the microflora inside a body depends on our habitual diet, age, ethnicity, and geographical locations, and many unexplained environmental factors. Dysbiosis, which means there is a disturbance in the microflora residing inside, can lead to dysregulated immune system and impaired intestinal lining or intestinal gut barrier, which may ultimately result in various disorders. The connect between microflora and the innate immune system is being hypothesized. The various ways, as Saurabh mentioned, to manipulate the gut flora are our habitual diet, use of probiotics, prebiotics, antibiotics, and FMT, and of course, we can use them in combination. FMT has been considered for various intestinal and extraintestinal diseases. I will be focusing mainly on those diseases, intestinal and liver disorders, for which there is some reasonable literature available. So we start with that what is FMT? It refers to infusion of a fecal suspension from a healthy individual into GI tract of another person to treat a specific disease. It should not be cure, but to treat a specific disease. The main indications of FMT are C. diff infection treatment, inflammatory bowel disease, irritable bowel syndrome, fatty liver, obesity, metabolic syndrome, alcoholic hepatitis, hepatic encephalopathy, CNS disorders like multiple sclerosis, autism, and recently it has been considered to be useful or may be useful for eradication of multi-drug resistant organisms. Now, I'll start with the most accepted indication, that is treatment of C. diff infection. Here, the evidence is good enough to put it even in the guidelines. As we can see here that FMT is mentioned in the guidelines, both NICE and European guidelines. And if you look at the evidence, it says that FMT is recommended as a treatment option for both mild and severe recurrent CDI infection. Its implementation in clinical practice is recommended. And for this recommendation, the quality of evidence is high and the strength of recommendation being strong. I think it leaves no doubt that for recurrent or refractory CDI, FMT is an effective, acceptable treatment option. Now, FMT can be used in combination with antibiotics, either as a sequential therapy or as a serial therapy. In a patient who's severe disease, we can start with antibiotics, give FMT, hold antibiotics for a few days, restart antibiotics, and if need be, we can give a second cycle, a second session of FMT again. Or if a patient has frank pseudomembranes, one can start with antibiotics like vancomycin till the time membranes are there, then one can give FMT so that the infection is really cured. We can achieve cure rates of more than 90% with this therapy, and there is a significant decline in mortality with FMT for both severe C. diff infection as well as fulminant infection. Now, having said that FMT is useful for recurrent, refractory C. diff infection, the question is that can it be taken as a therapy for any infection of C. diff? Means that all patients of C. diff, should they be subjected or should they be treated with FMT? Now, if you look at the data, vancomycin versus FMT as a primary therapy, or even compare it with metronidazole as a primary therapy, it may not do better than these antibiotics. So for mild infection, FMT is not really required. It may be required for recurrent infection or for refractory infection. To simplify, I'll say if a patient has a mild C. diff infection and is not responding to a traditional therapy for say 5 to 7 days, or if a patient has severe disease and is not responding to antibiotics for 24 to 48 hours, one can definitely consider FMT as a treatment option. But if you say that this is to be taken as a first drug for all patients with C. diff, that is not true. This was about C. diff. Now coming to inflammatory bowel disease. I'm not going into the history of use of FMT for IBD just to save time. I'll start with the 4 RCTs. 2 of these appeared in 2015, one in 16 and one in 17. 2 are from Australia, 1 from Netherlands and 1 from Canada. These 4 RCTs have been for induction of remission in patients with mild to moderately active ulcerative colitis. If we look at the RCTs carefully, there is marked heterogeneity regarding patient selection, treatment protocols, the route of administration, the placebo used. So it's difficult to really come up with a definite opinion. The total number of patients included in these 4 RCTs have been 271. Now, 3 out of these 4 RCTs for induction of remission were in favor that FMT fares better than placebo when used as induction therapy. However, as I mentioned the major differences earlier, one more major difference being the number of interventions. You'll be surprised to know that the number of intervention varies from 2 per patient to as many as 41 per patient. So there is a marked heterogeneity, as I've been saying. And overall, if you say the results are in favor that FMT is useful for induction of remission, but how and where to use it remains a decision to be made. Now, I will share with you our experience. For us in India, we all know that biologics are out of reach for most of the patients. So we have always been looking for something more low priced therapy, and FMT is one low priced therapy which can be done in a country. And a difficult to treat patients for IBD is patients who are on steroids for long term, or patients who require steroids and they become steroid dependent. So we started using FMT in these patients, and we were quite surprised that FMT produces really good results. We used in 49 patients, and in all 49, by 7 sessions of FMT, we used a colonoscopic approach. Every 4 weeks, we could successfully take them off steroids in all patients. Remission was there in 1/3 of the patients, with response in more than 50% of the patients. So we found good results, good response with FMT in patients who are on steroids for long term. Now, this was for induction of remission. We have used FMT for maintenance of remission, and this was the first RCT where we used FMT every 8 weeks. I would like to mention here that for induction of remission, we have been using FMT every 4 weeks, while for maintenance of remission, we have been using every 8 weeks. And here again, we used it for 7 sessions. And when we compared it with placebo, the red bar is placebo, the blue is with the standard of care plus FMT. All patients, they were on standard of care. So if you look at the figures, the clinical remission was higher in patients who were on FMT with standard of care, but it did not achieve a statistically significant difference. While for histological remission and endoscopic remission, the difference was statistically significant. So this proves a point that FMT is useful for maintenance of remission for ulcerative colitis. Now here we have used for patients who achieved induction, or where induction was also done with FMT. Now we are working on this, whether FMT can take over in patients where induction has been done with non-FMT medicines, non-FMT procedures. A step further, we looked at the data on clinical predictors of response to FMT in ulcerative colitis. So here what we see is a remission prediction nomogram in a patient with active ulcerative colitis receiving FMT. Now, of the various factors evaluated, namely age, disease duration, severity, extent, and endoscopic Mayo score, what we found that with increasing age, the chances of achieving remission was less. With M2, moderately severe disease, and with E2, that means proctosigmoiditis or E2 disease, not pancolitis, the chances of achieving remission was high. So increasing age has a negative impact on achieving remission, while the duration of the disease and the overall Mayo score did not have a major impact on prediction of remission. We have not been able to give our results based on microbiome analysis, but I would like to show here two things that the success of FMT, there are 2 points which are generally discussed. The microbial diversity of the donor. Now, who is a good donor? Like all antibiotics are not same, all probiotics are not same. And when we postulate that it's the microflora or the metabolites which are going to impact the response to FMT, then we can say that all individual donors, all individuals who donate can't be same, because no two individuals are same and no two individuals share the same habitat inside. So how to say that this donor is likely to be good or not? At the moment, what we have information that this depends on the microbial diversity of the donor, and what matters in addition to donor diversity is the resemblance of organisms between donor and recipient. Now, looking at Clostridium cluster 4 and 14 depicted in blue color and light color, if donor has diverse microflora and compatibility with recipient, there is a high chance that there will be a successful FMT. While if a donor may be good, but there is no compatibility with the recipient, there is a high possibility that the therapeutic benefit may actually not be passed on to the donor. So both these things we have to keep it in mind. Though at the moment we are really working whether it's the organisms what matters or whether it's the metabolites what makes a difference, we don't know really at this stage. Now, other issue is the acceptability and the safety and the tolerability of FMT in clinical practice. We have a data of more than 1 year. What we observed that symptoms happen quite often after FMT because we have been using mainly a colonoscopic approach or always colonoscopic approach. We have not used oral approach for ulcerative colitis. Abdominal discomfort, flatulence, and abdominal distension are fairly common, but these are minor symptoms and they go away within an hour or two. So these are the main side effects which we observe in these patients, but they are not worrisome side effects. We have data of 1 year also, where we observed that some of the patients they develop new symptoms like urticaria and flu, arthralgias, peripheral arthritis, axial arthritis, depression or allergic bronchitis, and one patient developed partial hearing loss. Now, arthritis can occur in IBD as it is. It's difficult to say whether it happened because of FMT or not, but because these patients were on FMT, so we have to count arthralgias or arthritis towards FMT related. So we mentioned that 8 patients that developed one or the other new side effect over more than 1 year's data record. Now this was regarding IBD. Now going on to other diseases, irritable bowel syndrome. The 2 RCTs appeared in 2020, both from Scandinavian countries. I'll start with the article on the right side. That this RCT is from Finland, where they used single colonoscopic FMT session for patients with irritable bowel syndrome, and they found that at 3 months or even at 52 weeks, the response was not different than placebo. When they checked various scores, symptom severity score, the difference was less than 50. The quality of life was also not different, though organisms did differ. That the patients who received FMT, their microflora was different, but it did not result in better therapeutics for irritable bowel syndrome. The trial on the left side is from again from Scandinavian countries, Oslo, and there they used placebo, 30 grams FMT and 60 grams FMT, and there they found that the green bar is 60 grams, and they found a significant improvement in the symptomatology when assessed on symptom severity score as compared to placebo. So there are mixed outcomes. Let's go to meta-analysis. Two meta-analyses have appeared when analysis included single arm trials and RCTs both. The results were showing or going in favor of FMT, that it makes a difference. But when single arm trials were excluded and only RCTs were included, then the overall result was that the response of irritable bowel syndromes on both scales of symptom severity score and quality of life score does not really matter. Now, these RCTs are not uniform, as there is a difference in the RCTs conducted for inflammatory bowel disease. Same is the situation here. Some of the RCTs they have used one session, while some RCTs have given a second FMT between 6 months to 1 year. So the trial which showed that FMT works for irritable bowel syndrome, they focused more on the microbiome and they calculated the donors dysbiosis index, and they found that the donor who was a super donor, because based on the microbiome pattern and the dysbiosis index being very favorable. So there are differences between the RCTs, but at the moment, if you say that meta-analysis suggests its place in irritable bowel syndrome management, at the moment we say no. The response or the results are not convincing enough. Coming to liver, oral FMT's capsules have been tried for patients with recurrent HE phase 1 trial. Recurrent HE patients, they were on standard of care treatment, rifaximin and lactulose, and oral capsules were given every day. It was mainly done like phase 1 trial for safety and the tolerability. It was found that FMT is safe and well tolerated, and the patients who received FMT capsules did better on encephalopathy scale. The hospitalization episodes were fewer in patients who were on FMT capsules. So this is one phase 1 trial only, but trial shows some promise. Two studies done in patients with alcoholic hepatitis, one from ILBS, Dr. Saline's group, where they use FMT every day for 7 days, oral route, in patients with severe alcoholic hepatitis who were steroid ineligible. And they found favorable response in these 8 patients. They used every day FMT for 7 days. Same group, the study is from Kochi. Abby Phillips, he is the author in both the trials. He compared FMT with other available therapies for alcoholic hepatitis, namely steroids, nutrition, and pentoxifylline. It's reported in Indian Journal that the response rate of FMT is better when we compare it with other available modalities. There are trials of use of FMT in fatty liver. The insulin resistance was shown not to differ or not to improve, but when intestinal permeability was looked at, it did control the permeability. But as such, there were not major differences in other parameters, including insulin resistance. So it's too early to say whether FMT can be considered for patients with fatty liver. But it's being tried. So what is the way forward? Have we reached some conclusion? To sum up, I'll say that irritable bowel syndrome, very conflicting results. Inflammatory bowel disease, results are showing promise, but at the moment we can't say that this therapy has got a place in the treatment armamentarium for irritable bowel syndrome, inflammatory bowel disease. We know that there are certain patients who are likely to benefit from FMT. For C. diff, there's no doubt it's an accepted indication. For other diseases, it's still a very experimental drug. Now, so far what we have been doing is FMT is with a very crude method. There have been advancements. We are not using the traditional blender. We have a stomacher which we find very easy to use and quite hygienically good. We don't need to clean it. It's totally disposable. Bags are used. But in future, if you look at it, there's more automation and there's more purification system. Gen FMTR is likely to be expected in future. Electroscan for microbiota. I was listening to my friend Dr. Vineet speaking on microbiome in IBD, and they are working on microbiome in ulcerative colitis, and their thought process is that the microbiome in stool may not matter so much. Mucosal or maybe the organisms which are closer to crypts may be more relevant. So the team is working on this hypothesis whether the microorganisms or microflora in stool is good enough or there is a good correlation with the organisms in the mucosa or not. Very interesting study. We really look forward to the results. As I mentioned that oral route, anybody will prefer. Colonoscopic route being invasive. When we talk of FMT, it's quite non-selective therapy. So can we be more selective in our approach? So for this, various steps which are being taken is that one, to prepare oral capsules. There's one study where oral FMT capsules have been used even for ulcerative colitis. The initial therapy was with colonoscopic approach. One session of colonoscopic FMT was done, followed by oral capsules every day. The number of patients, however, were very small, 6 or 7 in both the arms. The results are equivocal, not very much different from placebo, but there was a difference in the engraftment of organisms. Same, the capsules have been tried for other diseases like obesity. Results are not very promising. BMI was not different when assessed at 12 weeks or 24 weeks. When it comes to C. diff infection, oral capsules have been found to be effective. So situation in C. diff is different as compared to other diseases. Now, is there really a need to give whole of stool? Can we be more selective in our treatment part? So there is a concept whether there is a selective microbiota transplant or mini FMT can be thought of. So we have study where spores of firmicutes have been used as a therapy. So this is the first oral microbiome based study evaluating the efficacy of firmicute spores in ulcerative colitis. Here, the preconditioning was done with vancomycin, followed by either everyday spores or once in a week spores. The number of patients were evaluated were around 50. What has found that in patients where conditioning was done with vancomycin and daily firmicute spores were administered, they did better as compared to patients where once a week therapy was given or where placebo was used for conditioning rather than vancomycin. So vancomycin conditioning and daily administration of spores are two steps which show better response as compared to placebo. Long-term clinical use of FMT, at the moment we can say that there are many questions which remain unanswered, like what are the issues what we discussed when we talk of long-term use of FMT? The attributes related to donor and recipients being diet. Habitual diet of donor and recipient has a lot of impact on microflora. Our thought process is that even if we do FMT, if a patient's diet remains very pro-inflammatory, the result may not be sustained. So it's important to regulate or monitor the diet of donor as well as recipient. Donor screening and selection in the long run, it may not be possible to sustain the same donor in the long run. It may be, but it may not always be possible. So can we change donor halfway if somebody is on a long-term treatment with FMT? These are some of the issues which we really don't know at the moment. Whether donor microbiome analysis should be done once or periodically. How much is the intra-individual variation among donors? So these are some of the issues which we need to work on. Whether single donor is good enough or multi-donor pooled FMT should be the choice. Now this brings in a concept of donor-recipient compatibility. There are both points for and against. If we have a super donor concept, if we use a multi-donor, it's quite possible that super donors, super bugs may get even diluted. The host genetics, the microbiome analysis, gut cytokine analysis, the role of concomitant therapy. These are some of the other issues which are of great relevance when we opt for patient selection. So patient selection, that who should be actually receiving FMT, and the diet of a patient and recipient both, and the compatibility between the two are attributes related to donor and recipients, while attributes related to the procedure are that are we certain that we are giving a very safe medicine to the patient. The adverse events, we have 1 year's data but not beyond that. Still, the risk of transmission of unknown pathogens remain. They may manifest 5 years down the line. We can't say at the moment. This may ultimately result in development of other immune-mediated diseases. The fear is there, evidence not there for or against at this stage. What should be the standard protocols for patients' acceptance? Obviously, oral route will be preferred by the patients, but regarding ulcerative colitis, we strongly feel that colonoscopic approach looks more practical or more pragmatic approach rather than oral route. Duration of therapy will depend on what are you assessing, whether we are doing the mucosal healing or our endpoint is achieving the organism and graft, and how often should we use it. It will differ according to induction of remission or whether our goal is maintenance of remission or even prophylactic. So these are some of the important issues which we discussed. So my last slide is that I may not be there as yet, but I'm closer than I was, not yesterday, I will say 6 months ago. Why I'm saying so? Because of this pandemic, our program is on hold for past 6 months. So I wish the pandemic goes and the snail starts moving again. Thank you.
Thank you, Dr. Sood, for a very comprehensive review of the topic. You rightly covered up the GI part, and there are associations with non-GI diseases as well. But before we begin the Q&A session, I have one question, which is a basic question. Whenever we talk of gut microbiome and FMT, we talk of gut dysbiosis. So what exactly do you mean by gut dysbiosis? Is it the numbers? Is it the diversity? Is it the immunoregulatory mechanisms? Is it the metabolites? So what exactly do you feel that gut dysbiosis is?
Dysbiosis is a word that when we say that there is a disturbance in the microflora, this may be either in the numbers or maybe loss or gain of one community or abundance of a particular species. I would like to mention here that no two individuals have a same microflora. So it's not possible to use a word like this is a normal healthy microflora. So whenever there is a disturbance or the flora gets perturbed, we say that there is a dysbiosis. You're mute.
Saurabh, I hand over to you.
Thank you, ma'am. So thank you, sir, for this masterly presentation. So there are a few questions from the audience. The first question is that what are the patient-specific criteria for FMT, or it means that which type of patients with ulcerative colitis would you prefer FMT, or would you like to do FMT?
Very practical question. Now, the RCTs have included all patients with active ulcerative colitis. There's no mention that what stage they thought of induction of patients into RCTs. Now, what we have used in patients with moderately severe patients with steroid dependent ulcerative colitis. So, I will say that is one situation. Mild to moderately severe steroid dependent ulcerative colitis is a definite indication. Moderately severe disease where biologics can't be used, that can be another situation. I would like to share with you that there have been instances when FMT has worked even for patients where biologics have failed. We also have a couple of such patients, and literature also reports a couple of such patients where FMT worked even after the failure of biologics. So this is not a straightaway indication, but a situation where if you have nothing in hand, one should try FMT. But if you ask me, sort of that at the moment, can we say that this is a well accepted modality of treatment? I'll say that based on the four RCTs, Cochrane review was done, and their analysis was also that at the moment the evidence is not robust enough to put it as a definitive therapy. I will say that this should be used at few select centers where they have experience and they have regular use of FMT.
It should only be used in a research setting or a trial setting.
At the moment, yes.
So next question is from Dr. Ramakrishna. As to for weekly FMT in UC, so do you use the same donor or different donors at each session, and single or multiple?
Uh, we are using a single donor. There are two reasons why I prefer single donor. This donor is unrelated to the patients. We are not using patient-related donors. In India, even stool donation is a taboo. Now, actually, it's very problematic. Easier said than done. Because for donor, he is to pass the stool in a container, which is not physiological, and then he has to store a sample for some time. We can't keep at a room temperature in summers, so it has to be refrigerated. Now he needs a separate refrigerator. Obviously, nobody will let him keep the samples even in the room. So this is a problem. Now with us, now we are using FMT, so we have a person who goes to donors' home in the morning and collects sample. And number three, in India, infections are very common. It's difficult to do screening of donors again and again. So we are that way fortunate that our donor is young, healthy, and the family history is good. And so far we have a satisfactory response, so we are persisting. Overall, we have three donors. So when one donor is not available, we go to number two or three. But active donor is one, two donors are in reserve.
And at what frequency do you screen the donor, like with a questionnaire or the stool test?
3 months.
3 months. And do you prefer the diet of the donor, vegetarian versus non-vegetarian, or that does not?
Our donor is vegetarian. If you ask me, I'll any day prefer a vegetarian diet.
My next question is related to your last slide. The pandemic is not going to end in the near future. So what is the way forward? How do we start or restart or with the FMT? So what is your take on this?
Yes, it's a very, very important issue, and this has been bothering all of us. I'm sure it has been bothering your team also. So, what is the issue that if we depend on only nasopharyngeal swab, RT-PCR, we know that some of the patients they may not have symptoms and they may still be excreting viral particles in the stool with RT-PCR from the throat being negative. So, there have been articles which suggest that one should combine nasopharyngeal swab examination with serology. If both are negative, one can consider collecting the specimen. Such a sample should be sent for stool PCR also. If stool PCR is negative, this donor is good enough. While if we don't have facilities for stool PCR, then we should quarantine the sample for 8 weeks, recheck donor again. If negative, then we can use the sample. Now it seems a very tedious procedure. What we are trying is we are trying to convince that we should go for stool RT-PCR, and if negative, that makes our job easier. So far, actually, Punjab was going through a very tough time. Even now, sort of Delhi and Punjab are no different now. We are having a really high prevalence at the moment. So I think I was just hoping that once there's a tide towards slow down, maybe we can consider if we have facilities for stool examination, we can consider starting. But I'm not in a hurry to start.
From Dr. Manish is to can FMT be is FMT only useful in left pancolitis or it can be used for left-sided as well as proctitis?
According to our study of clinical predictors, it worked better in left-sided as compared to pancreatitis, but it's not a contraindication. No age is contraindication. It's only that it's the prediction of remission. The chances of remission are higher if it is left-sided as compared to pancreatitis, or even proctitis. Proctitis also doesn't work as well as it works for left-sided.
In view of your experience with FMT, what do you suggest about some regulations being drafted for the country or for some centers where it is being carried out in an active way?
No doubt, I can see the legal books behind you. so, so the question is very apt, right? There is the rules are very different in different countries. Some countries take FMT as a drug. Some countries take FMT as a tissue, while some countries are silent. Like India at the moment is silent, but we have a SOP in place, and we are recording the data. And if we look at it, the risk of transmission of infections, unforeseen infections, can't be ruled out. So, to be on the safer side, one should use it very, very cautiously, and every patient should be documented. There should be regulations, like there are regulations for other drugs. I will say this is not truly a transplant. It is transplant when we do a transplant. Now, if you do a corneal transplant, that whatever you transplant, kidney transplant stays in place. Here, when we do FMT, if we say it is microbiota transplant, we know that not more than 10 to 15% of the organisms which are actually transplanted, they are engrafted. Or some of the donors may not get any expansion of the organisms. Or some of the species may stay as long as 1 year or longer. So it's not truly transplant. I prefer to use the word microbiota transfer rather than transplant.
So there's a difference in the nomenclature which you are putting forth.
Right, right.
Okay. So FMT still remains as a black box to many unanswered questions. So what do you think in a country like ours where biologicals are not being used? Do you feel that in IBD, in ulcerative colitis, could this be one of the modalities for treatment in our patients?
Uh, right. At the moment, if we think of it, the research in IBD is going in two directions: microbial science and biologics, poor man's science and rich man's science. See, for West, they say nothing compared to biologics. we can't deny the fact that biologics are the most effective way of treating IBD. We can't deny that. But at the same time, if you look at it, look at our own registries data, that how many people they actually got biologics, 1.5%. If you look at the figures in the West, 20 to 30% of patients of their IBD patients, they go on biologics. So there's a huge gap. So for our country, we are always looking for something cheaper. Thankfully, even colonoscopy procedure is not that expensive in our country as compared to West. And for institutes like PGI, AIMS, it's free. So FMT, if both therapies are equally effective, it may be more suitable for countries like ours, where economy and acceptability of FMT is higher.
Saurabh?
So when do you call a patient as non-responder to FMT? When do you decide that the patient is not responding to FMT? How many weeks or how many sessions?
Right. This is very variable in different patients. Now, if we, after FMT, we have observed sort of some of the patients, they deteriorate, say, after session 6 or 7 also. Very unexplained phenomena happens that there are some patients who have been doing well on FMT. When it was decided treatment protocol that okay, 7 sessions are to be done, there were few patients who deteriorated in 6 after 6 session or 7 session. Normally, the response comes by 2 or 3 sessions. If a person deteriorates after even a first session, we have to accept it as a failure. If patient response is somewhat there is a response, but not complete response, we can carry on for 2 to 3 sessions.
Sir, questions from the audience. So, Dr. Manish is asking, can we add FMT to steroid-dependent UC, which is not fully controlled on biologics?
Yes, concomitant use of biologics, steroids, immunosuppressive agents is no contraindication. But it's better if we withhold biologics. Now, biologics, infliximab is the one which is being used in a country. As it is, its cycle comes after 8 weeks. So if person doesn't respond, we can always combine the two.
And another question is that in resource-limited settings in induction of IBD, can we go for FMT in day-to-day practice?
At the moment, I will say no. We have to have more data. We have to collect more data and then sit together and then find a place for FMT in the treatment algorithm. That yes, if it is a 3-tier system or 4-tier system, we have to identify its place. That this is after patients who are mild to moderate, they're not responding, then one can consider FMT.
And any comments on stool banks?
Very, very relevant question for our country. Now, you know that we have a stool bank in our hospital. We have storage facility. We call it as a stool bank. We are storing samples at minus 80 degrees, though we are using more fresh samples. But we are storing samples at minus 80, and we have good number of samples stored from donors. In our country, even blood banks are not regulated so meticulously. So this really raises a question: how stringently can we really regulate the stool banks? But if we think of it that all centers will be able to have their own storage facility, will not be possible, because once it becomes an option for clinicians, or once we say this is an accepted indication, then definitely physicians in practice or private sector have to go to stool banks to collect the specimen. There is definitely requirement of stool banks, there's no doubt, but it will need very stringent regulations and control.
And what about microbiota-based oral therapy, the capsules?
I mentioned that there's one study, which is the first oral microbiome-based therapy. Spores of firmicutes used with preconditioning with vancomycin. The response rate is good. I always wish if we could get some spores of, say, Faecalibacterium or Bifidobacterium, combine 2 or 3, and then administer for Crohn's disease. But again, then question will come, as we always discuss, whether it is really the metabolites what matter or not, whether it is just the organisms. But if we induce the organisms, they will obviously influence the metabolism inside, and they might produce metabolites also. I think more data is to be collected on this issue, but this is a very, very interesting area to work.
We've discussed about IBD and the GI part. There have been news about other diseases making a headway with FMT therapy. So some of the neurological diseases. What interested me was the eternal youth, which was being mentioned as one of the treatment modalities for eternal youth. The cognitive decline decreases with FMT. So how far do you think that for non-GI diseases, we should be using FMT therapy?
There are some issues. Definitely, now there's one patient where FMT was used for GI indication. That patient had multiple sclerosis. He dramatically improved after FMT. So that raised a possibility whether multiple sclerosis can be helped by FMT or not. We have one patient of multiple sclerosis who comes to us for regular FMT. Not for last 6 months. He was visiting us every 2 to 3 months. According to his own assessment, he was getting better. But the issues will be what should be the route. Now for IBD, at least I am clear in my mind that colonoscopic approach seems more justifiable route. For irritable bowel syndrome, it could be either oral or colonoscopic route. For non-GI disorders, it seems oral route is more logical. Now oral route seems more logical. So obviously capsules have to be administered. So if we have capsules, I will say definitely in situations where one can try oral route FMT is autism or ataxia or various these indications.
There's a lot of NASH coming up in Punjab.
Yeah.
So would you like to add the questions?
Ma'am, there are many questions from the audience. So, sir, one question is related to the safety of FMT, and another is related to the role of FMT in Crohn's disease.
Role of?
FMT in Crohn's disease.
Okay. The history goes back to 4th century when it was used as a yellow soup in Chinese medicine. Children who had diarrhea, there it was used as a yellow soup. A stool from a healthy donor was taken and it was infused through oral route. Those good old days, there was no informed consent forms. So there was no litigations. So patients accepted because there were no litigations. Obviously, nowadays we can't do anything like that. Gradually went on. 17th century, it was used in veterinary science for animals. Transphonation is the process called. There it was used for treating various large animals. Then came the role of FMT for staph-induced pseudomembranous colitis. Ultimately, it was a doctor who had ulcerative colitis who ingested, and he had a very long-lasting response with that. So there the story started that it works in ulcerative colitis.
Crohn's disease.
Yes, Crohn's disease, again, in inflammatory Crohn's disease, there are studies which have shown for induction of remission as well as for maintenance of remission, but surprisingly, there's no RCT for Crohn's disease at the moment. The initial case reports or case series showed a better response in Crohn's, but till date, there's no RCT on use of FMT in Crohn's disease.
And sir, the issue on safety of FMT, especially after the 2 reports of MDR E. coli transmission.
Definitely, they were MDR. One of the patients was immunocompromised. and he had UTI also. But we can't get away from the fact that one has to be very cautious. That's why you ask how often do you screen your donor. So we need to have a periodic check on the donors and take all the precautions. Now, if we say that FMT is a the content is a sterile content, obviously it is not a sterile content. It can't be. But if we see the stomacher what we are using and compare it with the blender what was used initially, there is a huge difference. The blender can never be cleaned. It can never be. One can never say the blender is absolutely clean because there's so many services and there's so many, you know, dishes in that. So either person has to have his own blender. Even then, it can't be cleaned every time. So what we suggest that the stomacher what we are using is fairly okay. I hope that you also have got the same stomacher with you, Saurabh,
Yes. Yes.
right? So I'm sure that you will agree that this has made preparation so much easier.
Yeah.
So I'll say that infection risk is there. We can't forget it, and we need to be watchful. That's it. That's all we can do. There are so many. The risk of infections is there. Like we all use antibiotics, so common, so rampant use of antibiotics. The risk of fungus and other infections with antibiotics is so much. So that way, the risk of infection is there for FMT also.
And sir, another question: the role of FMT in patient with acute severe ulcerative colitis.
Sorry, I couldn't hear the question.
Sir, role of FMT in patient with acute severe ulcerative colitis. This is again a question asked by the audience.
Acute severe ulcerative colitis, there are few case reports. Honestly, we have not tried in acute severe ulcerative colitis at the moment, but there are few case reports where it has worked. As I mentioned, that where biologics failed, this might work at times. But we don't have much experience of use. At the moment, if you ask me, I will not recommend. I will say either biologics or cyclosporin.
And another question, sir, interesting question: is the consent for FMT different from other informed consent?
We have to write that some of the issues are not clear at the moment. We have to write down that some of the infections may or some of the immune diseases may come up tomorrow. We can't say.
And sir, another question is the dose for FMT different for different indications? Dose and route.
Right. Different doses have been tried 30 grams and 60 grams, 60 to 80 grams. We have been using 60 to 80 grams and 200 ml of saline. So that makes it 250. When we use oral route, obviously dose is less. The dose is 30 grams in 100 ml. So for chronoscopic approach, the dose can be higher. For oral route, the dose is less. But oral route we don't use in certain patients that those who got dysmotility or diverticuli or previous history of surgery or if there are adhesions. These are some of the situations where the risk of bacterial overgrowth really increases tremendously. So we avoid oral route in these patients.
And so another question from Dr. Rajiv. So how do you position FMT versus biologics in the current scenario?
In steroid refractory ulcerative
I will
colitis.
say that I will say in moderate severity disease, I will definitely use FMT before biologics until unless there is a contraindication. But at this moment, we have to offer it to a patient. We can't say this definitely works. So patient factors, patient decision is also important for this decision. Biologics, sort of, if we say really 98% of the patients, they can't afford biologics in a country at this moment. Until unless insurance company comes tomorrow to help us. As we discussed the other day that daycare daycare treatment is not covered by insurance companies. And biologics administration in infliximab is daycare. So that way, biologics coverage is very, very less. For prompt response, biologics are more effective. FMT, we don't expect a very prompt response. It is a slower acting drug.
I think we are done with the questions. Any last moment comment, Dr. Sood, would you like to give?
No, thank you so much. I'm grateful to you and Dr. Saurabh.
Thank you,
and the audience for being with us on Sunday.
Thank you very much. Thank you, Saurabh. Thank you, Dr. Sood, for a nice session. And we continue with our IBD webinar next time, and we would let you know before that. Thank you very much.
Thank you, ma'am.
Thank you.